herniated discs do occur in adults. We just don't see them as frequently, or I'm sorry, not in adults. In patients over 50, we don't see the disc herniate out as frequently over 50 because the disc is, like I said, it's the degenerative process. The disc tends to calcify a little bit and harden, so that soft part tends not to squirt out. Plus, as we get older, it becomes less soft. But you have some people that have perfect looking discs and they're 90 years old and out pops the disc herniation and you say, I'm surprised. And so we do see older patients than 50 with disc herniations, but the more common thing we see with leg pain over 50 is stenosis, and that's crowding of the nerves, not individual nerves, and it's usually down both legs. When you stand and walk, you feel it, and you sit down and you can make it go away, and you know, I can only stand and walk for 10 minutes, or I have to use a grocery cart, and that helps, then I can do 20 minutes or 30 minutes or whatever. And that's spinal stenosis, and that's this crowding. You see this is one of those discs that I was talking about that's hardening, it's getting flat, and it's getting bone spurs pushing into the nerves as they come down. This is your back, a profile view there. Conditions are multifactorial in general. Once in a while we see someone that said, yes, I picked out the fertilizer bag and I felt this pain just shoot down my leg, and that's obviously an acute disc herniation from bending and lifting, and we see that quite a bit. But what we see for chronic pain is people without a inciting event. They just know that over the last 5 or 10 or 20 years, and you see my paperwork when you come in, when did your pain start? Sometimes it says 50 years ago. So I say, well, why'd you come today? You know, well, I ignored it for as long as I could, and that's, I tell patients all the time, well, that's pretty good, you know, that's, you're doing okay. So, but it's often multifactorial, not caused by, but associated with things like smoking or peripheral vascular disease, deconditioning, obesity, and genetics. We see young people frequently in a spine clinic with terrible looking backs, and they didn't have any trauma or any problem, and we don't know if there's an environmental exposure or what happened to cause that. We think it must be genetics. But there is no proof that this is a genetic disease for some patients that have these backs that look much older than the patient can look very healthy. And you look at the MRI and you swear, this couldn't be that patient. So there's some genetic predisposition, and there may be also an environmental exposure relation as well. Then you have known associations that you know this must have done it, or the patient knows. They say, well, you know, I've been working as construction all my life and things like that. And you know that these people had excessive exposure to stresses and strain in their back. But I remember very well when I moved to Richmond, we had movers. I moved from Chicago to Richmond, and we got from Chicago, we paid the mover and the company, and like 20 kids, all in their 20s, came, and they moved the stuff out within an hour. And it wasn't that much stuff. We had a little apartment. And when we got to Richmond, the other team from Richmond met us there, and there was 2 guys, and they were both in their 60s, and one was short and fat, and one was tall and skinny, and they had to go up the stairs. In Chicago, we had an elevator, okay? And I'm just amazed, how did these guys do this? And they'd been doing it all their life. So the opposite is true for good backs. There's probably maybe some genetics, because these were not healthy guys that moved us in. So that was my academic insight there in Richmond. For genetics go both ways, could be for good or could be for bad, you know, like the Winston Churchill. Next. A lot of times we try to simplify it when patients come to the office, or other physicians try to simplify it, and the patient says, I know I have arthritis in my back. And arthritis is a specific medical term that describes disruption or a loss of integrity to a joint. And so in your back you do have joints, but the disc isn't a true joint. A joint is a piece of cartilage surrounded by fluid with 2 bones that connect so the body can move that part of your body. So in the spine, technically we don't use the term arthritis, but you hear it all the time. And it's the same thing. It's a degenerative process. This is showing a patient that or a person that maybe had an MRI for low back pain. And as a physician, when you see this MRI, you think it's pretty good. I mean, this disc doesn't look like these discs. And anyone can see that. You don't know if this person, based on the MRI, has any pain at all. And we see MRIs like this all the time in patients anywhere from 15 to 85 with perfect discs except for one. And people could just have mild back pain that they worried about for years and get MRI. Or you could have someone in the office that's not able to stand up and crying, and you look and this is all you see. And you say, oh. So it's a spectrum. Same thing with osteoarthritis. We see people with a knee x-ray, they don't have any cartilage, and you just happen to take an x-ray because they didn't complain about pain. You thought something was different on the exam. And you say, you don't have a cartilage left. And they say, well, I don't have pain. And you say, well, you need a knee replacement. They say, no, I don't. I mean, so the arthritis, the pictures don't match the pain. Not everyone with arthritis has pain, and not everyone with pain has bad arthritis or degenerative problem in their spine. Other problems that we see in the back could be a tendon or a ligament issue in or around the spine. Maybe this has nothing to do with it. It could be a pulled muscle or a strain to one of the tendons or ligaments. We think about things like infection and tumor, and then there's the unknown causes. We've had a lot of patients that have had thousands and thousands and tens of thousands of dollars in workup and even surgeries and still nothing. Well, we have to try to figure it out. If you come to the office, we're going to do that, and that's what the physician or the surgeon will do. You'll get a full physical exam that includes a test of strength and reflexes and to test the neurological structures that come out of the back, down the legs and arms. Next. We usually take x-rays. Although imaging study may not be helpful early, it's always indicated for a trauma or injury. We usually are seeing people after they've had pain for a few weeks, so it's time to at least consider x-ray. X-rays sometimes show a lot. Patients know now MRI shows more. They don't know what more, but they know they need MRI. So they're right, it does show more. But x-ray shows a lot. X-ray shows the bone, and sometimes when you see the x-ray, you know everything, and so the x-ray is very meaningful. The MRI you always get, even if you get the x-ray, they show different things. The MRI is a special imaging study that shows the soft tissue very well. The soft tissue includes the disc and the nerves and the joints in the back of the spine. And the x-ray shows the bone very well. And the x-ray doesn't do the best at the bone. CT shows the bone even better. So if you're really concerned, you could end up with x-ray, CT, MRI, and if the doctor is still confused, something called a bone scan. And so there's a lot of advanced imaging studies, but generally it's x-ray, and if that's not showing exactly what MRI, and MRI is very good and helps to determine what's going on to cause it. The treatment depends on the problem. For mechanical back pain, we think of as a cushioning problem, the main treatment is make that stronger, because you can't replace the cushion. You have to support it. You have to support the structures. For leg symptoms, when the nerve is the problem, the best treatment is to take the pressure off the nerve. And so we have a variety of ways we could try to do that. We try non-surgical treatments first. Even if patient has severe pain and they're screaming, we don't necessarily want to take them to surgery right then if there's not new numbness or weakness, bowel or bladder problems. You can give them pain medications and reassure them that this can heal itself. Even giant disc herniation, your body is remarkable in the ability to heal itself. Same thing with spinal stenosis. No, your body won't take the pressure off the nerves, but we see patients with the stenosis is 100%. There's really no room for those nerves. But somehow a patient's walking and has normal sensation and reflexes. The body adapts. And so a lot of what we try to do is allow the body to adapt and make the patient comfortable while the body learns how to adapt. We can do it through counseling, education, rest, medications, physical therapy, exercising and stretching, restoring motion and strength, getting blood to the tissue, augmenting the supportive structures around the tissues. I tell the patients all the time, it's like the cell phone towers on the side of the road. Your spine is just a skinny column, like those cell phone towers that you see. They don't stand 100 feet or however tall, some of them are really tall, up in the air by themselves. They have cabling all around them that support that structure and keep it strong. And that's your core muscles, the stomach, the abdomen, the glutes, the hamstring, and quads. And so augmenting those supportive structures, getting the core muscle in shape will help to relieve the pressure from the spine column. It's helpful to relieve pain. Which exercise is the most effective? Therapists are the experts at that. And we have therapists, and the hospital and other therapy centers have specialists in back, hopefully. We have dedicated equipment for back alone. Some other things that the therapists can do, we have braces. We can give prescription and fit for a brace. There's good evidence that braces don't work, and there's good evidence that braces can make things worse. But braces are good for certain problems.